Without further ado, let's get going here. Gastroenterology case review. Here's our first case. So we have a 42-year-old obese woman presents to the emergency department with abdominal pain of several hours duration. So first couple things that pop into your head. Nope. Good. That's fine. That's fine. That's fine. You can, I mean, we can spend all day, right? Abdominal pain is something that is just like, it's so wide. Like, it could really be anything. They don't tell you anything else but the age, the gender, and that she's obese. So you really don't have much to go off of. So just, pop out 2, 3 differential, and then we'll just keep it moving, okay? So the pain began shortly after she ate a slice of pizza at her son's birthday party. Describes the pain as constant, localized to the right upper side of the abdomen, right upper quadrant, right? Admits to having previous episodes of similar pain, but adds that these episodes spontaneously resolved. Physical exam reveals a temperature of 100.9, pulse of 113, blood pressure is normal. Abdominal exam is significant for right upper quadrant tenderness and positive Murphy sign. Okay, so definitely cholecystitis. Very good. And so that cholecystitis is our diagnosis. What would be your next best step? I agree. Right. Right. Um, okay. So from yeah, very good. And so diagnostics wise, what options do you have? Ultrasound. Very good. Good. Very good. Okay. And so most likely, you said cholecystitis. I agree. Next best step would be ultrasound. If your ultrasound is equivocal, and I get we're getting kind of into advanced things here, but what are some options for you if you can't really make the diagnosis from ultrasound? HIDA scan. Excellent. Very good. So, in general, just kind of getting our terminology here. Complications of gallstones. So, biliary pain, anytime you have that obstruction of the gallbladder, and the gallbladder tries to contract, that's going to cause a biliary pain or biliary colic. Cholangitis is an inflammation of anywhere in the tract, not just the gallbladder, but anywhere in the common bile duct, the cystic duct, hepatic duct. An infection anywhere in there would give you a cholangitis. Okay. Cholecystitis, this is typically an obstruction of the neck of the gallbladder, not net. And this is going to be our classic presentation. Obstructive jaundice. If you have a patient with obstructive jaundice, you're looking for an obstruction in the common bile duct. Okay, so this is a big kind of dichotomy between your cholecystitis and obstructive jaundice because both of them are due to a stone, right? However, in obstructive jaundice, here you're having the stone that made it out of the gallbladder and is now lodged in the common bile duct. So a lodged in the common bile duct means all of your bilirubin is going to be stuck upstream, okay? And so expect to see, a jaundiced patient, elevated bilies in the bloodstream, that dark colored urine. You can see increased alk phos because alk phos is an enzyme that is in the wall of the common bile duct. You can see increased GGT, another enzyme that is in the wall of the bile duct. So those are two sort of lab findings that are pretty helpful in terms of diagnosing a obstruction in that common bile duct. Okay. GGT is gamma glutaminase. It's GGT, gamma glutaminase, and it's an enzyme that is located, like I said, in the cells that line the common bile duct. Okay. Why is GGT important? Because there's another way to get an increase in alk phos. Okay. Yes, alk phos is in the lining of the common bile duct. It's also in bone. So if you have a patient who has some condition where they're having increased breakdown of bone, say osteomyelitis, multiple myeloma, any of these conditions where bone's being broken down at a high rate, that can give you an elevated alk phos too. So with obstructive jaundice, you want to see increased alk phos plus increased GGT. And that tells you that this cannot be from bone. It must be from your bile duct. Okay, great. Pancreatitis, if your stone gets all the way to the ampulla of Vater at this point now, not only are we going to have those symptoms of obstructive jaundice, we also may develop a pancreatitis. All of those pancreatic enzymes, your tryptase, all these amylase, all these enzymes are now breaking down the pancreas instead of breaking down, the food in the duodenum. And so this is going to cause a much more severe presentation. Gallstone ileus. What is a gallstone ileus? Aside from the description right there next to it. So, that's okay. So, there is one small problem with people that have had gallstones for a long period of time. So, here's our gallbladder. Here's it. It's emptying from the cystic duct. Here's the common hepatic duct, giving to the common bile duct, which will empty into the duodenum. Okay, and so here's the second part of our duodenum. And so it's coming out over here. This is all duodenum. Okay. When you have patients that have had gallstones for a long period of time, these gallstones, instead of progressing out of the gallbladder, out of the neck of the gallbladder, they can start to form a fistula between the gallbladder itself and the lumen of the duodenum. Okay, and that's just from all the inflammation and all of that, just weighing down that gallbladder onto the duodenum. You can have a fistula form, which is an open space between that gallbladder and duodenum. Okay. As the gallstones are now here in the duodenum, the gallstones are going to continue throughout the small bowel. They're going to go through the jejunum, through the ileum, and at the distal ileum, right there at the ileocecal junction, we have a narrowing, right? It's almost like an ileocecal valve. That narrowing is going to cause an obstruction if a gallstone blocks it, right? So that's going to be one of our causes of a small bowel obstruction, which is one of the cases we're going to talk about later. But I thought I'd introduce it now as one of the sequelae of having gallstones in your gallbladder. These gallstones and all the inflammation they cause can allow for a fistula to form and for gallstones to pass through. Okay? Great. So this patient definitely has acute cholecystitis, which is essentially just that inflammation of a gallbladder wall. While this is an itis, there may or may not be bacterial growth. We don't assume that there is bacteria here just because it's an itis. This may just be due to irritation of that gallbladder wall pushing against that obstruction. Okay. When we remove our gallbladder, what we expect to see is an enlarged gallbladder, discolored serosa. Typically, we do see stones obstructing the neck or the cystic duct. Subtypes of cholecystitis, we have a gangrenous cholecystitis where we actually have some coagulative necrosis. When we take this gallbladder out, it's going to have a nasty black color. These gallbladders are prone to rupture, so it's one of those things we can be concerned about. There's also patients that are in the ICU. Patients with sepsis or burns can develop acalculous cholecystitis, meaning they have all of the symptoms of acute cholecystitis, but there's no stone. And what the cause of this is actually just ischemia. So any patient that becomes hypovolemic, they're going to lose the nerve stimulation of their gallbladder, and that will allow things to just sort of hang out there, and you end up with cholecystitis. Okay. Clinically, very classic presentation, which is why I like starting with this one. That steady right upper quadrant pain. It may even radiate to the tip of the right scapula or shoulder. This is because of referred pain, right? So our phrenic nerve is sort of all in this area. Phrenic nerve refers pain to the scapula, to the shoulder. And so that's something that we can look for as well. It should be on the right side. The same side as the gallbladder is where we see that radiating pain. Fatty food intolerance, because the gallbladder cannot emulsify fatty foods. Murphy's sign that we saw in our patient. And our cardinal signs of inflammation: fever, nausea, leukocytosis with a left shift, meaning lots of neutrophils. Okay? When we do our WBC, look for neutrophils. On ultrasound, we look for stones, sludge, pericholecystic fluid, gas in the gallbladder is possible, and an ultrasonic Murphy sign, meaning when we press our ultrasound probe in that right upper quadrant, we get a Murphy sign. That's all that means. Okay? Recurrent attacks can lead to chronic cholecystitis, and we'll kind of look at what that means on the next slide. Complications acutely, we can have some pus in the gallbladder if we have some bacterial etiology. We may have a rupture or perforation of the gallbladder, which is not good. and peritonitis, where we would see free air under the diagram if we did an X-ray. Okay, cholecystectomy, easy go-to. We can perform it laparoscopically. Great. So we talked about our diagnosis. If ultrasound is equivocal, we're going to do a HIDA like you told me before. In terms of treatment, these patients should be hospitalized. We're looking for broad spectrum IV antibiotics. Okay, so think third generation cephalosporins. Okay, is typically what you want to go for. Maybe a cefoxitin is a good choice. IV fluids and replete our electrolytes. Early cholecystectomy, and that's about it. If patients are stable, and this is one area that they can kind of trip you up. If patients are stable and they have significant medical problems, don't go straight to the OR. Okay, we're going to delay this. We want to stabilize our patients before taking the gallbladder out. Okay, so great. So let's talk about our chronic cholecystitis. So these patients that have had recurrent bouts of acute cholecystitis end up with a hypertrophied wall, a really thickened wall of their gallbladder. Okay, these repeated bouts, history of acute attacks, we're going to see that thick wall, sludge in the lumen, gallbladder stasis. On histopathology, we can look for these Rokitansky-Aschoff sinuses, not terribly important. But what is important is on the X-ray, what we look for is a porcelain gallbladder, meaning we've had a bunch of calcium that's now deposited in the wall of that inflamed gallbladder. And so our gallbladder is going to look nice and bright on our abdominal X-ray, which is something that they can show us on a question stem and expect us to know. Okay. One of the problems with this porcelain gallbladder is you have a much higher risk of gallbladder carcinoma. Okay, so you got to take it out, which is obvious. Patient is typically in the 7th decade. So painless, palpable gallbladder. I want you to think carcinoma, either a gallbladder carcinoma or pancreatic carcinoma. Okay, pancreatic carcinoma. Why do we see a painless, palpable gallbladder? The reason is because when you have cancer in the head of the pancreas, it obstructs the common bile duct. And because it happens so slowly, rather than presenting with the classic signs of choledocholithiasis, these patients instead present with that painless, palpable gallbladder that you can feel in the right upper quadrant. Okay? So, painless, palpable gallbladder, think either gallbladder carcinoma or a cancer in the head of the pancreas. Very good rule of thumb. Okay, great. Any questions on gallbladder stuff before we move forward? Okay, can I ask you one question then? Okay, so here's our gallbladder. Here's the neck of our gallbladder. Here's our hepatic duct, common bile duct, and here we are at the ampulla. Right, here's our duodenum. Great. So we said that a stone that gets lodged in the neck here is, acute cholecystitis. Great. What do we call a stone here in the common bile duct? There's a that would be further, correct? Yes. So this is a very specific name. It's called choledocholithiasis. Choledocholithiasis. You've heard of this one before, right? No? Okay. So choledocholithiasis, all this means is that you have a stone in the common bile duct. Okay? This is one of those terms that you may see. I wanted to make sure that we went over it so you're comfortable with that. Okay? Great. Yep, you're welcome. Okay. So, next. We have an 83-year-old woman presents to the ER for abdominal pain. What do we think? Just a quick differential. Mm-hmm. Mm-hmm. Sure. Yeah, that's perfect. Yes. You have your differential. You're going to focus in on the question and start eliminating things as you go through, and it's going to help you get to your answer. So this patient was in her usual state of health until approximately 8 hours ago. Began experiencing crampy pain in the left lower quadrant of the abdomen. Since the onset of her symptoms, she's vomited twice, has not had a bowel movement. Physical exam, she is febrile, a pulse of 109, blood pressure is normal. Abdominal exam is significant for left lower quadrant tenderness with guarding. Okay. Rectal exam is notable for rectal tenderness. Complete blood count reveals a white blood cell count of 14, hemoglobin of 13, and platelet of 200. Okay. Excellent. Great. So, I love that you said diverticulosis and Crohn's. If you had to choose from one of those, considering what you know about the patient, which one would you go for? Think about the epidemiology of those two conditions. Right. Excellent. I love it. Yes. Diverticulosis is absolutely correct. And so what I was getting at with epidemiology is that as we age, as we collect birthdays, everybody on this planet is going to end up with some diverticula in their colon, right? That's just life. That's just how it goes. Now, depending on how many diverticula there are, and depending whether or not one of those diverticula gets obstructed and then fecal matter is stuck inside, is going to determine the severity of the presentation. Okay? And so this particular patient definitely has diverticulosis. I agree 100%. But she's got something on top of that. So, I've just told you that basically anybody over age 70 has a diverticula. Not everybody over age 70 has, left lower quadrant tenderness and guarding, right? So this particular patient definitely has something more severe going on, okay? So here's where we're going to start to think about, and you can see the white blood cell count. What do you think of this white blood cell count? High, right? Great. So anything, and she's febrile, good. So here we're thinking of diverticulitis, which is one of those diverticula. I hear you. I was the exact same way. So diverticulosis is just any outpouching. Diverticulitis is when you have an obstruction of the neck of that little pouch that... Yes. Excellent. Yes, absolutely. They would give you something for inflammation, number one. And number two, patients with a regular diverticula that's not infected would not be tender. They would not have pain. They would actually be asymptomatic. Okay? The only way that you would possibly know that a patient has a diverticula is if they had some rectal bleeding. Okay? Blood per rectum, one of the most common cause, I think the most common cause of blood per rectum in a geriatric patient is a diverticula. Okay. And so that's basically the way they would present. So I like the way you're thinking here. What are some of the things that really clue you in that this is a diverticulitis? So the first thing you said, that, having that inflammation, having that lower abdominal pain. And I want you to really look at where the abdominal pain is. Left lower quadrant. There's really not too many things we talk about in left lower quadrant, right? It's usually the right lower quadrant. For our, appendicitis would be right lower quadrant. For left lower quadrant, that's where our sigmoid colon is. And believe it or not, that is actually the most common place to have diverticulitis. So if you have a patient, elderly, left lower quadrant pain, febrile, then you should really strongly be thinking about diverticulitis. And then if they give you the white blood cell count on top of that, then it's boom. Okay, I already have my diagnosis. Click the answer, go to the next question. Okay, and so diverticular disease in general, these are just outpouchings of mucosa and submucosa through the colonic muscle layers in areas of high pressure. Okay, so the descending colon, sigmoid colon, those are going to be our high yield places. most commonly sigmoid colon. Diverticulosis, most common cause of acute GI bleeding in patients over 60. This is an important fact to keep in mind because, when it comes to GI bleeding, the first thing we always think is, oh my God, GI bleeding, colon cancer, right? And we should think that because that is, yeah, exactly. Yeah, we need to do a colonoscopy. We need to figure out what's going on. And that's sort of like we always have that hairpin trigger to think colon cancer when we see GI bleeding, which is great because we want to rule that out. But if you look at the statistics, and this is a way that they can kind of trick you on the exam, the actual most common cause is going to be diverticulosis, although you're going to do the colonoscopy anyway. Okay. So risk factors: a low fiber diet, a high fat diet, advanced age, connective tissues disorders. So these really rare things: Ehlers-Danlos, Marfan syndrome. Those very rare connective tissue disorders have a higher association. Diverticulitis is due to inflammation and possibly even a perforation of one of those diverticula. Okay. Diverticulosis, like we said, is typically asymptomatic. If we do see bleeding, it's going to be a painless bleeding. Okay. Your patient will come in saying, I see a little bit of blood on my toilet paper after I wipe. I'm not sure what's going on. I'm not having any pain. And then you look for hemorrhoids. You don't see hemorrhoids. Probably this patient's got diverticulosis. So look for symptoms of anemia if it is, if they do have that bleeding. Diverticulitis, like we said, left lower quadrant pain, fever. You may see some constipation. Perforation is very serious, right? Perforation is always going to be a reason that you need to probably have your patient go straight to the OR, especially if you're in the primary care setting. This patient needs to go to the emergency rooms very quickly. So uncomplicated diverticulosis, what treatment are we going to give? A high fiber diet is really all you need to do. Fiber supplements, that's going to decrease the amount of pressure in the colon and prevent further diverticula from growing. Mm-hmm. Good. Okay. Yeah, no, that's an excellent point. And so when it comes to Crohn's, ulcerative colitis, in those particular conditions, we really want to sort of treat the underlying cause. And so, exactly, avoid triggers. We want to give anti-inflammatory medications like our mesalamine, our sulfasalazine. Those drugs those are basically aspirin that don't get broken down until they get to the colon. Okay, and so colon in the aspirin basically is going to decrease the amount of inflammation in those particular diseases. And when you decrease the inflammation, that means you're going to decrease the diarrhea, decrease all those symptoms. Okay, so avoiding triggers, but also you got to treat the underlying disorder. Okay, excellent question. Good question. So for diverticulitis, here we need bowel rest. We're going to give them an NG tube, broad spectrum antibiotics. You can think of metronidazole plus fluoroquinolone, a second or third generation cephalosporin. We said cefoxietine, still a great choice. And one very important point, we want to avoid barium enema, flexible sigmoidoscopy, colonoscopy. All of those should be avoided if you're suspecting diverticulitis. Why? Excellent. Yes, you are 100% right. If we have just an inflamed diverticula, we should think of this thing as being a very, very gentle piece of colonic tissue. So increasing the pressure with that barium enema, sticking a giant camera in that area is not advisable. So here we are going to definitely avoid that. Okay. So this is a very high yield point they can ask you about. Okay. Great. So let's look at a couple pictures here, just sort of giving us the dichotomy between diverticulosis and itis. Here's a regular diverticula. And so these are considered false diverticula because they don't involve all three walls of the GI tract. They involve the mucosa, the submucosa, but they do not involve the muscle in the wall of the GI tract. Okay, so one sort of caveat there. And so we can see the diverticula are just these little outpouchings. If we have some of this fecalith that gets stuck inside, that is going to obstruct the entrance to the diverticula. We can have anaerobic bacteria growing inside. And ultimately, if they're allowed to grow for long enough, we can have a rupture of that diverticula. Okay? Very good. Yeah, exactly. So, the goal here in treating with that high fiber diet is by decreasing the pressure, we may allow some of these diverticula to come in a little bit, but now you have that permanent weakness, right? That weakness is not going to go away. And so if your patient ever stops with the high fiber diet, right, starts binging on, pizza and potato chips, these diverticula are going to come back. Okay, so it's really all about maintenance and preventing diverticulitis in the future. Okay. One last screening thing that is very important. It's been kind of a change over the past 10 years. When you have a patient with diverticulitis, we already talked about what we do. We admit them to the hospital. We give them antibiotics, fluids, all that stuff. Once we discharge them, they need to return to have a colonoscopy within the next 48 months. Okay, within the next 4 years, these patients need to return for a colonoscopy. The reason is, what's been found is that patients who have a bout of diverticulitis have a high risk of developing colon cancer in that same area. Okay, so all of this, regardless of age, exactly. And so, there are already screening guidelines for a lot of these patients. We said that, these are typically geriatric patients, so they should be getting colonoscopies anyway. But if they have diverticulitis, now our suspicion is even higher. They need to return for a colonoscopy. Okay? Excellent. Okay. So we have a question here. This one's for you. Mm-hmm. Take that one out. Great. Excellent. Very good. Very good. So, like you said, we're treating with those third generation cephalosporins. They are great because they cover gram positive. They also cover some gram negative. Okay, they kind of have that dual part of the spectrum. And so the answer here is that they would be infected with gram negative or gram positive. They could be really infected with both. Okay. And typically what you find in these diverticula is that if you have diverticulitis and it ruptures, you really have a mix of bacteria, right? Anything that living in the gut is going to be in that diverticula. So, okay, great. Very good. Okay. So we have a 42-year-old woman presents to her primary care physician with a chief complaint of flushing. Yeah, just first things that pop to your head. Mm-hmm. Mm-hmm. Good. Yeah. I like it. Great. Yeah. We'll just go on from there. So these episodes arise suddenly and spontaneously without any trigger she can identify. Episodes last about a minute. However, she describes one episode that continued for 15 minutes. Great. During these episodes, the skin on her chest and face becomes very red with a mild burning feeling. Over the past few weeks, she has also had increasing problems with diarrhea, has had up to 20 watery non-bloody stools per day. That's a lot. accompanied by intense abdominal cramping. Denies any health problems prior to these complaints, which began a few months ago. Physical exam, she appears comfortable with normal vital signs. Faint wheezes are heard on her lung exam, and she has mildly hyperactive bowel sounds, but her abdomen is soft and non-tender. Okay, C. diff. It's definitely a possibility. Watery stools, with that cramping sensation, I agree 100%. Now, that covers the abdominal part. What about the flushing? That's the thing that we really have to kind of make gel with our whole diagnosis. Okay. Okay. So this would definitely be something to rule out. What would be your course of action to rule out C. diff? What would you want to do? Good. So stool culture and toxin, right? Look for C. diff toxin. Great. Okay, so both of those come back negative. So electrolytes are normal. So I think that some patients that have low blood pressure can develop flushing. That's definitely something that we can see. However, when you have this weird sort of constellation of signs, the cramping, diarrhea, plus flushing, this is going to be associated with something called carcinoid syndrome. Okay? A carcinoid, that's that tumor that you get in the GI tract that creates serotonin, right? Yeah. So in terms of next best step, the test that we want to do here, if we're thinking that there's a lot of serotonin, we want to look for breakdown products of serotonin, okay? And so what we do is we do a urine 5-HIAA, okay? What is 5-HIAA? It's really just a breakdown product of serotonin. And if we see a lot of it in the urine, then that tells us that there's a high chance she has a tumor that is secreting serotonin, okay? Great. So 5-HT is serotonin, and then serotonin gets broken down into 5-HIAA. Yeah. I'm not sure why they don't check for just 5-HT. That's a great question. Seems like that would be a more direct way of testing for it. Maybe it's harder to identify, but yeah, I'm not really sure why, but yeah. So they check for this breakdown product. So lab testing we just mentioned. Great. So carcinoid syndrome and carcinoid tumor. Two little different things. You need one to get the other one. So your carcinoid tumor, it's a neuroendocrine tumor. All that means is that it's a tumor that secretes some sort of neurotransmitter. Okay, and so this particular one, the main offender here is going to be serotonin, although there's also some histamine and prostaglandins that are secreted. Serotonin is going to be causing all of the problems in these patients. So it's going to stimulate intestinal motility, causing that diarrhea, right? 20 bouts of watery diarrhea a day, not fun. And so serotonin might be what's causing that. Intestinal motility and secretion. It also causes cardiac valve fibrosis. Okay, so tricuspid valve is going to be the most common place where you see that fibrosis and stenosis secondary to serotonin. Clinically, we're going to look for flushing episodes with diarrhea and wheezing, and right-sided cardiac valvular lesions. Okay. Some triggers include exertion, excitement, or eating, or in the patient that we had, there may not be any strong identifiable trigger at all. Typically, these are going to be located in the small intestines. Now, here's where we get into the difference between carcinoid tumor and carcinoid syndrome. So, the most common place to have a carcinoid tumor is going to be right there at the terminal ileum. Okay, so here's the terminal ileum. Here's our colon. Branching off our ascending colon, right? So as this tumor is growing, it's going to be secreting serotonin into the blood supply. That's going to enter the portal venous blood supply, which is going directly to the liver. Okay, so there's our beautiful liver. So all the serotonin that's secreted by this tumor is going to go to the liver. Okay. Now the liver is great because it's going to break down all that serotonin. Okay. So if you have a patient that has a tumor in their small intestine, the patient is not going to know. The patient is not going to have diarrhea, not going to have flushing, not going to have any of these symptoms because the serotonin gets broken down before it can go systemic. Okay. So that's our carcinoid tumor. Now, carcinoid tumor is a tumor like many others that can metastasize. So once this carcinoid tumor metastasizes to the liver, and now we have little mets here in the liver, when it secretes serotonin, its serotonin is going to go directly into the systemic blood supply. So now that the tumor has metastasized, now our patient is going to have symptoms. Okay? So any patient that has carcinoid syndrome has metastasis. Okay, it has to be there because we know they're not able to clear serotonin. Okay, all right, great. So, how do we diagnose this? We're going to test the urine for 5-HIAA, very sensitive, very specific, and then we can confirm the location with a CT scan. Treatments, we can give a somatostatin analog, which actually neutralizes serotonin, as well as neutralizing the serotonin's effects at many organs. And that's going to be sort of a temporizing measure. Eventually, we do need to resect that tumor and debulk some of those hepatic metastases. If we cannot debulk them, if these metastases are unresectable, we're going to have to go with chemotherapy. So 5-FU, doxorubicin are our go-to drugs. Okay? All right. Great. So, just sort of a diagram showing what sort of happens with many patients with carcinoid tumors and why it's so important to be able to identify the symptoms. So this is a patient with a carcinoid tumor. Here's year 0 of them having the carcinoid tumor through year 20. And you can see the tumor just grows and grows and grows for about 6 years. Okay. And during that time, the patient may not have symptoms or may just sort of have vague abdominal symptoms. We may think about an irritable bowel syndrome, a gastritis, colitis, sort of these vague, ethereal sort of symptoms. However, as the tumor starts to metastasize and those metastases start to grow, now we're getting the flushing and diarrhea. Now that you see flushing and diarrhea, now you really think about carcinoid. However, at this point, we already have a huge tumor that's been growing for 16, 17 years, plus all these metastases in the liver, the lungs, and at that point, it's going to be very, very difficult to treat. And so for a lot of these patients, unfortunately, they may die due to their tumor load before we're able to, debulk it or remove it, do chemotherapy, what have you. Okay? Great. So our high yield points from carcinoid syndrome, these are enterochromaffin cells that secrete serotonin, presents with flushing episodes, diarrhea, wheezing, right-sided cardiac valvular lesions, typically located in the small intestine. If we see the flushing, we see the symptoms, that means that there are metastases. Okay? So any patients with unexplained flushing and diarrhea should have their urine tested for 5-HIAA. This is something that, patients are not going to go to the emergency room because they're having flushing and diarrhea, right? They're going to go see their primary care. So this is something that we really need to be aware of. Treatment-wise, octreotide, this is not a drug that I instantly think of when I think of yeah. So essentially, it's just a exogenous somatostatin. Somatostatin is a hormone that basically never met another hormone that it liked. Okay, somatostatin everywhere in our body decreases the levels. So in our pituitary, it decreases levels of growth hormone. In our pancreas, it decreases levels of both insulin and glucagon. In our stomach, it decreases levels of our of gastrin. Okay, so all over the body, somatostatin decreases levels of hormone. Okay, and so giving it in this particular case is just going to be targeting that serotonin. All right, wonderful. Any questions? Mm-hmm. Mm-hmm. Yeah. So the side effects for octreotide are going to be vast. They will be vast. And sort of those are things that we need to sort of deal with as we get to. And that's why I said that this is really a temporizing measure. We're having patients with diarrhea 20 times a day. Okay, now we're going to have to deal with hypovolemia, and your patients are not going to be happy. They don't want to go to the bathroom 20 times a day. So we can give octreotide as kind of a bridge until we figure out how we're going to deal with this tumor. Okay? Yeah. Good question. Okay. Our next case here, we have... Mm-hmm. Sure. Okay. No problem. Yep. Okay, great. So, just sort of looking at the time, I skipped case 4. Case 4 is about this pretty rare condition called primary sclerosing cholangitis. I'm sure you know about this one. It's associated with ulcerative colitis. It basically presents with jaundice in a young male. All of the information is going to be in the PDF when I send it to you, but I want to kind of go over some of the more high-yield diagnoses in our time together. Is that okay? Okay, great. So, a 46-year-old man presents to the emergency department for having 3 episodes of hematemesis during the past 3 hours. Okay, so talk to me. What are you thinking with a middle-aged man with hematemesis? Mm-hmm. Yep. Yeah, good. Blood is coming somewhere out. Yeah, exactly. Good. Peptic ulcer. I love that you said that one too. So somehow blood is getting into the esophagus, right? That's what we know. So we have to think about the ways that can happen. What you mentioned before, some esophageal varices, I 100% agree. Peptic ulcer disease, very important cause. Maybe a Borhave syndrome where you have a rupture of the esophagus, Mallory-Weiss. All these things can be included, right? But there's blood in the esophagus. How did it get there? So this gentleman admits to many years of alcohol and heroin abuse. Physical exam reveals a temperature of 100.1. He has a pulse of 102. Blood pressure is normal. While supine, however, he is hypovolemic, or I guess he has a low blood pressure while upright. Can't really say hypovolemic. Abdominal exam reveals a distended abdomen with splenomegaly, caput medusae, and a fluid wave. He is anecteric and spider angiomata are present on his thorax. Neurological exam is unremarkable. Relevant labs, albumin of 2, bilirubin of 3, PT of 25 seconds, which is elevated. And our AST is 200, ALT is 250. Okay? And so, what is our most likely diagnosis here? Absolutely. So when we have things like varices, we can have varices in our esophagus, which leads to, hematemesis like this gentleman. We can have hemorrhoids, which is, just dilations of vessels in our rectum. And the third way for us to have varices are veins on the abdomen around the umbilicus. Okay. And so if this is our abdomen, here's the umbilicus. Caput medusae are dilated veins on the abdomen, sort of radiating from the umbilicus, but they can also be a little bit, proximally and a little bit distally. But essentially, caput medusae are just dilated veins on the abdomen. Okay, and they are a sign of portal hypertension, which is the cause of the varices everywhere else. Right? That's the cause of the esophageal varices and the hemorrhoids is because of portal hypertension. Okay. Okay, great. So, we know that he is having hematemesis, right? Not necessarily. I mean, they could go together, but in terms of the diagnosis, really, we want to say that he's having some sort of esophageal bleeding, right? And the esophageal bleeding, with this history of alcohol and heroin abuse, and the fact that he's jaundiced, what do you think the underlying problem is? Yes, liver, great. So cirrhosis, so this would be like esophageal bleeding secondary to cirrhosis. Okay, excellent. So next best step for this gentleman, right? He's vomiting blood, so we definitely need to somehow tamponade that bleeding. We need to stop that bleeding from continuing. So that would probably be the next best step. He's also, he's got a low blood pressure, and so we definitely need to start fluids and make sure that we can get that blood pressure up. How is prognosis determined? So this is something called the MELD score. And this is probably a little bit too, this is kind of like some gastroenterologist type stuff, but essentially in terms of determining prognosis for these patients, we look at the INR, we look at the bilirubin, and we look at the PT to determine what their prognosis is. Okay. By the way, speaking of bilirubin, what do you think of this patient's bilirubin? Is this high, normal, or low? Elevated. Excellent. Yeah. So for our normal bilirubin, we want to look for a bilirubin around 2. So 3 is definitely going to be elevated. Great. Very good. So, yes. Yeah, no, I'm glad you asked that because I meant to mention that and I forgot. So there are times where AST and ALT will give us a lot of information, and there are times where it's going to give us 0 information. Okay, so times where it gives us a lot of information. If your AST is, So if your AST is double your ALT, 2 times ALT, then you have an alcoholic cirrhosis. Okay. If your AST is double your ALT, so there we would look for an AST of 400 and an ALT of 200. And that tells us that the cause of the cirrhosis is alcoholism. Okay? Yeah. Yes, they're both elevated. But the AST is double the ALT. Yeah. Exactly. As long as the AST is double the ALT, you can think about alcoholic cirrhosis. Okay. The other situation where we can get a lot of information from AST, ALT is whenever you see an AST, ALT and they're, say, in the 3,000s, 4,000s, right? When they're in the thousands, you want to think of a viral hepatitis. Okay, so Hep A, Hep B, any of those acute hepatitis infections, they have a vastly elevated AST and ALT. Okay, in cirrhosis, what's happening is your patient has lost capacity of their liver to do anything. And so liver enzymes, yes, they're elevated because we're having breakdown of those cells, but they can never reach 4,000 because we don't have enough hepatocytes. The cells have been destroyed forever. And so we would never be able to get that elevation of AST, ALT. In hepatitis, you have a patient who has a normal liver, but they have this acute infection on top of it. And so all of their hepatocytes that were just fine 5 minutes ago have now burst open secondary to this virus. And so there you see a vastly elevated AST, ALT. You're going to see numbers like 4,000, 5,000 for your AST, ALT. The ratio is not going to be important in that case. In that case, we're really just looking for that huge elevation in the thousands to tell us that, okay, this is a viral hepatitis. Okay? Great. So cirrhosis in general, we have hepatocellular injury that leads to fibrosis. This is key. This is not just a hepatitis where you have an inflammation of the liver. We have had an injury for such a long period of time that we're now fibrosing our entire liver. We're putting down scar tissue there. Okay, that takes some time. So if you look sort of at your histology, you see things called nodular regeneration, loss of architecture. That just means that instead of having this normal structure, you have a lot of fibrosis and scar tissue in your liver. So it should be shrunken down. Because of this shrunken down liver, we're going to see liver dysfunction. We'll see portosystemic shunting. This is our varices. So esophageal varices, our caput medusae. You asked me about caput medusae before. I'm not sure if you can see this image really clearly, but if you see it, there's these blue veins. You see these blue veins? Sort of. Yeah, you'll be able to see it when you download this PowerPoint. But there's these bright blue veins that are going all along this dilated abdomen. And so those are your caput medusae. Okay? So esophageal varices, caput medusae, and our hemorrhoids are all of the portosystemic shunts. Okay? Most common cause is alcohol and chronic viral hepatitis. Other causes include NASH, non-alcoholic steatohepatitis. This is our patients who are obese. Obese patients end up having deposition of fat within their liver, which can lead to cirrhosis. Okay? Hemochromatosis. Yeah, fatty liver. Yep. This is a fancy name, right? Fancy name for fatty liver. Hemochromatosis. This is an overload of iron. It's a genetic disease. Wilson's disease is an overload of copper, another genetic disease. Alpha-1 antitrypsin deficiency. Okay, this is our genetic and inherited cause of emphysema. Okay, alpha-1 antitrypsin is an enzyme that breaks down another enzyme that breaks down lung tissue. Okay, and so essentially that enzyme is called elastase. Alpha-1 antitrypsin is supposed to break down elastase. If you don't have alpha-1 antitrypsin, you're going to have a lot of elastase. It breaks down your lungs, and you end up with emphysema at age 8. Okay, and so the two organs that we look for in alpha-1 antitrypsin are liver and lung. Okay, if you see a patient who's young with emphysema and cirrhosis, think about this particular genetic condition. Primary biliary cirrhosis is an autoimmune condition that causes cirrhosis. This one is more common in females. And congestive heart failure. All right. So symptoms, all the symptoms of cirrhosis are what you would expect. So weakness, muscle cramps, weight loss. As the cirrhosis gets more advanced, your patients are going to lack appetite, have nausea. Female patients will not be menstruating, impotence, gynecomastia. We can also see things like spider angiomata, which are red dilated arteries, or capillaries, I should say, that are in the skin. They look a bit like this. You may see them on the back of the hand, just some dilated spider angiomata. The palms of our patients are going to look bright red. And Dupuytren's contractures are when the tendons in our hands become tightened, essentially. And so your patients are going to have hands that kind of look like this. I'm not sure if you can see me on the camera. Yeah, so their hands are going to end up looking like this because the tendons in their hand are all going to be contracted. That's called Dupuytren's contractures, and it's something that we see in cirrhosis. Okay. Liver labs, elevated AST and ALT, decreased albumin. Why? Liver makes albumin, so that should be decreased. Increased bilirubin. If we do our coag panel, we will see an increased PT and an increased PTT. Because the liver is responsible for making all of our coagulation proteins, now we're going to be missing those. Okay. We should be performing ultrasound on any patient suspected of cirrhosis where we would be able to make that diagnosis, seeing the fibrosis, echogenicity, atrophy, etc., etc. Because the liver is such an important organ, when it dies, we're going to have a lot of problems that we need to treat. So first thing we need to be aware of is what you mentioned before, peritonitis. When we start to have a lot of peritoneal fluid called ascites, that fluid can get infected by a bacteria, okay? And that can be actually quite deadly. That infection can progress rapidly. Our patients can get hypotensive. They can become septic. And so any patient that has either cirrhosis or some sort of GI bleed, like the hematemesis we saw in our question stem, should be getting antibiotics. Okay? These patients need to have their Hep B and Hep A vaccine. And when I was learning this, I said, why am I worried about a hepatitis vaccine? This patient's liver is already completely shot. I don't think, why are we worried about doing a vaccine at this point? Well, okay, maybe this patient only has 25% of their liver capacity left. Do we really want to complicate that and make it 5% by having a viral infection on top? Probably not. So give that Hep B vaccine, give that Hep A vaccine, okay? This is 100% something that you can see on your exam in terms of preventative care, okay? Oh my God, always. Mm-hmm. Mm-hmm. That's so funny. That's so funny, yeah. And you know, the funny thing about the AANP exam, it's not, I mean, I say this with a grain of salt, but it's not that many questions, right? Like, you learn all of this different stuff, all this different pathology, anatomy, pharmacology, preventative care, and then you only have 175 things they're going to ask you about. It's not really a fair representation of what you know, I feel like. Especially for you, who you came so close to passing. It's not terribly fair, and so you may end up with questions on your next go round, but you're going to be ready. So in terms of diagnosing hepatitis from those markers, how do you feel about it? You're good with those? Okay, good. They're coming up in a later case, so in any case we can review it anyway. But good to know that you're feeling pretty good about it. Awesome. Our 23 ppv vaccine. What is this for? What are we vaccinating against with 23 ppv? Mm-hmm. 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 Yep. Yep. Yeah, I think it's 5 years, and I believe it is 5 years, but the most important thing I think is the order of the vaccinations, and so you got to have that. I always just remember that 13 is before 23. Yeah, it's just like, exactly, yeah. The simplest ways to remember things are the best for me, and so yeah, so you're absolutely right. You want to do the 13 and then 23. Okay. For these patients, we're just going to do the 23 rather than doing the 13 because these patients we can kind of consider as immunocompromised. The 13 is a protein-based vaccine, and so the 23 being the sugar-based vaccine in terms of the... Exactly. Yep, you got it. Good. So our patient had some variceal bleed. They were bleeding from their esophagus due to a dilated vein in their esophagus. What do we need to do? Okay, so IV resuscitation. We need to get that blood pressure up. We may need to do a blood transfusion. Esophagoscopy and banding. So doing our upper endoscopy allows us to see where the bleed is coming from, and we can also kind of block where the blood is coming out of. And so what that involves actually is putting a rubber band right around the bleeding vein and kind of clotting it off in that way. Okay. Octreotide, this one comes back again, not because we're looking to block the serotonin. Octreotide actually is going to dilate the portal venous supply, which basically decreases the amount of portal hypertension. Okay. So this is going to decrease portal hypertension. Okay. The exact mechanism, don't worry about, but just know that is the goal, we're decreasing portal hypertension. Okay. Prophylactic antibiotics, again, to prevent against SBP. In terms of, generally, once we get out of this acute phase, what should we tell our patient? We need to decrease salt and protein to minimize fluid retention. That's the salt part. Salt is going to increase our fluid retention, so we want to decrease the salt. And because these patients have difficulty breaking down ammonia, we need to restrict protein. The breakdown of protein is ammonia. That's how, that's sort of the way we get it out of our body is in the form of ammonia. But when you have this liver condition, you're not able to get rid of ammonia. And so encephalopathy is a big concern for these patients. So we need to restrict protein for that reason. Okay. If we see ascites, we can go ahead and diurese this patient to try and reduce that ascites. If our patients are resistant to diuresis or there's some sort of other complication we're concerned about, we can just basically stick a needle into the abdomen and drain out some of that fluid. That's a paracentesis. Okay. Complications of cirrhosis include HCC, hepatocellular carcinoma. So how do we keep an eye out for hepatocellular carcinoma? We're going to do a liver ultrasound and check AFP every 6 months. Every 6 months, we're going to do an ultrasound and we're going to measure AFP levels of the serum. Okay? Alpha-fetoprotein is a marker that we really associate with pregnant women, right? This is one of the things that we can see elevated in our quad screen. But it happens to be associated with hepatocellular carcinoma, and that's really the only cancer that it's associated with. And so it is a helpful marker to have. Let's watch out for that spontaneous bacterial peritonitis, these varices. Hepatic hydrothorax is essentially when we have ascites in the pleural space. And so, this is going to look like a patient with respiratory difficulties that also has cirrhosis. Okay, that's how you would identify that. We would treat that particular complication with salt restriction or diuretics. All right, great. So high yield points, just the hepatocellular injury secondary to alcohol and viruses that leads to fibrosis. For labs, we can look for AST, ALT, albumin, bilis, increased coag panel. Ultrasound will also help us with our diagnosis. We need to give antibiotics for anyone with cirrhosis or GI bleeds. Make sure we give those vaccines. And then we talked about all of these other complications, how we can treat them. All right. Any questions on this stuff? Sure. Yep. Mm-hmm. Yeah, absolutely. So, you've worked in the hospital, right? So when you are using the ultrasound, whether you're doing a bladder scan or whatever else, you don't have great resolution, right? Like even the best ultrasound operator, you can't really finely determine things. You're really looking for large abnormalities or large pathology. And so the way that I think about ultrasound is, number one, it's very quick. Okay, we don't have to wait to take the patient down to CT and yada, yada, yada. We can grab a machine, no radiation. Yep. So Yep. That's the first thing for kids too. And number two, we need to think about what are we looking for. So for example, think about a colon cancer. With colon cancer, you really need to be able to see the entire colon to figure out where the actual tumor is. With an ultrasound, that would take a very, very long time, and you're not going to have a good resolution. So that would not be a good choice. However, if you're looking at one organ, it's going to be readily identifiable, and you know what you're looking for. In a small space, ultrasound's usually a good bet. Mm-hmm. Yeah. Mm-hmm. I agree. 100% I agree. Yep. Mm-hmm. Good. Yeah, that's a great question. Okay, so we have a kind of bonus question for you here. So we have a non-alcohol using, non-IV drug user, abstinent patient who presents with advanced cirrhosis. What sort of lab testing would you like to perform? And so what I'm asking here is, what are some other causes of cirrhosis besides viral and alcohol, essentially? Right. Okay, sure. Shoot your shot. What you got? Mm-hmm. Good. Yup. Bilirubin, right? Mm-hmm. Yeah. Good. Yeah, absolutely. So those would absolutely tell you all the functioning of the liver. Once we see that there's something wrong and we know our patient is not doing all these other things, we have to start thinking about these really rare other causes of cirrhosis. So the alpha-1 antitrypsin levels we talked about before, that being a disorder that affects the lungs and the liver. Okay, so alpha-1 antitrypsin we can look for. Anti-nuclear antibody and anti-smooth muscle. These are going to be associated with our autoimmune hepatitis, leading to cirrhosis. Anti-mitochondrial antibody is associated with primary biliary cirrhosis. We said this is a very rare cause. This is typically going to be a young woman who presents with cirrhosis. We could think about PBC. Ferritin transferrin levels. This is going to be associated with hemochromatosis, which is a genetic buildup of iron in the blood. 24-hour copper, ceruloplasmin. These are associated with our Wilson's disease, which is an overload of copper in the blood. And last, our hemochromatosis is, again, hemochromatosis. It's just a genetic test we can do. Okay? All right. Very good. Okay. So our next case here. We have a 47-year-old man presents to the emergency department with colicky abdominal pain that has lasted 5 hours. Okay, so what pops into your head? 47-year-old colicky abdominal pain. Mm-hmm. Mm-hmm. Sure. Yeah. That's sort of the fun but unfun thing about gastroenterology is that when you say abdominal pain, the list is like this long, right? There's so many things that this could be. Yeah, always. Mm-hmm. Right. Absolutely. Right. Yep. Absolutely, yeah. There's all of these referred pains, and there's so many things that this could be. Is our patient pregnant? Like, what is going on? So here we go. So, yep, everything you said, I agree with. So we'll just keep going here. He reports 2 episodes of feculent vomiting and a bowel movement 10 hours ago. Physical exam reveals a afebrile temperature, pulse of 92, blood pressure slightly elevated. Abdominal exam reveals a mildly distended abdomen with a well-healed surgical scars, okay, and diffuse tenderness. High-pitched, hyperactive bowel sounds are noted. No hernias are appreciated, and rectal exam is unremarkable. Okay, so. Mm-hmm. It's something. Good. Excellent. Yes. Yeah. So this is a patient, with the vomiting and not having a bowel. I mean, 10 hours is not a long time to not have a bowel movement. I feel like I don't know what your schedule is, but for me, that's not that long. Right. And so this question, I might want to change a few things after this particular class to this question to make it a little bit more point in the right direction. But yeah, you were right. This is going to be an obstruction, and the things that point us towards that. So we have the vomiting and not having a bowel movement, colicky abdominal pain with small bowel obstruction. What ends up happening is we have that thing called peristalsis. Every time peristalsis moves down the GI tract and hits that obstruction, he gets pain, and it goes away. Now another wave of peristalsis comes a little bit later, boom, he gets the pain again. And so this is the way that he is going to present. Seeing that distended abdomen definitely makes us think that he probably hasn't had a bowel movement in some time. And the well-healed surgical scars. So the reason that I think that this is so important is because the most common cause of bowel obstruction in adults is actually going to be something called adhesions. When we have a surgery, and an abdominal surgery, for example, maybe a gallbladder surgery that is an open gallbladder surgery, appendectomy that is an open appendectomy. When we have those surgeries, they go into the abdomen, they're moving stuff around, and then they close everything up. What ends up happening is parts of the peritoneum that's lining our GI tract gets stuck to the upper part of the abdomen. Okay, and they actually form very strong fibrous bands. Okay. Now, when this patient is just going on living their life, at some point that fibrous band may press on the open hole of our GI tract and actually cause an obstruction. So the most common cause of small bowel obstruction in adults is actually going to be those adhesions. Okay. And so when you see this well-healed surgical scars, you were right to kind of like be suspicious of that fact, because that's a huge thing for your diagnosis. The other big thing for diagnosis is hearing these high-pitched bowel sounds. The high-pitched bowel sounds is basically telling you that you have an obstruction, but little bits of air are getting past the obstruction. That's kind of like the high-pitched noise of just air passing past that obstruction. And that is typical of small bowel obstruction, is high-pitched sounds. Okay? Great. So, next best step. What can we do for this gentleman? Excellent. I agree 100%. And then, sorry, I didn't mean to cut you off. Okay, yeah, we might need surgery, absolutely. And then, so our three most common causes in adults, number one is going to be our adhesions, we said before. The second one is going to be a hernia. And so if we have a umbilical hernia, a inguinal hernia, femoral hernia, any of these areas where little bits of bowel can poke through the wall and get stuck, that's going to be our second most common cause. And the third most common cause is going to be some sort of a tumor. So maybe a lymphoma in the wall of the bowel, maybe even a carcinoid that we talked about from before. That's going to be our third most common cause. Okay? Great. So, small bowel obstruction. Simply a blockage of bowel contents through the small bowel. We can have a complete or partial. Most common causes, we said before, adhesions is going to take up the vast majority. Hernias come after that. And then last is going to be neoplasm. If you have an SBO in a child, it's probably due to a hernia. Okay? And the most common hernia in children is an inguinal hernia. And so most likely you're going to be able to find that obstructed bowel right there in the inguinal canal. Okay? Great. So symptoms, we can look for colicky abdominal pain, nausea, vomiting, obstipation, which, patients are having difficulty stooling. If we're having passage of flatus or stool 6 to 12 hours after onset, that tells you it's probably a partial rather than a full obstruction. In terms of diagnosing it, look for those high-pitched tinkles, peristaltic rushes. Essentially, every time we have this wave of peristalsis, a little bit of air is getting past the obstruction, which tells you that is what your diagnosis is. If you start to see fever, hypotension, rebound tenderness, tachycardia, we need to go to the OR because this obstruction has now perforated. whenever you have a perforation of your GI tract, you have to go to the OR and you have to take out that perforation. Okay, perforation is a surgical emergency, and so any case where you're starting to suspect that this obstruction has become much worse than initially thought, you got to go to the OR. Okay. In terms of diagnosing it, and this is sort of a wishy-washy fact a little bit, but I left it in because it helps with kind of conceptualize what's going on. If you have a patient that's vomiting, and if vomiting is the primary part of the picture, you would think of a higher up obstruction. So obstruction maybe at the duodenum or the jejunum. However, if your patient is not really vomiting, but is really just sort of distended, you would think of an obstruction a little bit further along. So lower jejunum and going towards the ileum. Okay? So a patient who has that gallstone ileus is more likely to be distended than vomiting, if that makes sense. In terms of diagnosis, go ahead. Mm-hmm. 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 So that's a great question. Would you send this person right to the OR? So or the ER, excuse me. So small bowel obstruction, actually, it's not an emergency. It's not necessarily an emergency. If you have a perforated small bowel, yes, that's an emergency. They're going to be going straight to the OR. But this is something that you can handle on your own. If you have an x-ray in the office, you can do that abdominal x-ray, get your diagnosis, and then just manage it with supportive care. These patients can be sent home. And then asked to return maybe in 24 hours, 48 hours. Okay? So definitely abdominal x-ray is a great go-to. Looking for that dilated small bowel, some air fluid levels, confirm it with the CT. And then if you start to see a perforation, you can see elevated white blood cells, elevated lactate. Okay. Obviously, if the obstruction is complete with a vascular compromise, or you have an obstruction for greater than 3 days, you do need to go to the OR. Okay. That would be an emergency. Great. Okay. Any questions on SBO? No? Okay, great. All right. So here we have a 47-year-old patient who presents to the emergency department with mild abdominal pain he has had for the past 24 hours. Okay. So I won't make you say your differential out loud because it's kind of the same thing again. So we'll just say ditto from the last question and keep it moving here. He's noticed an increase in his abdominal girth, has been feeling intermittently confused. He adds that last year, another physician told him that his liver was bad. Physical exam, he is febrile. He has a pulse of 104 and a slightly elevated blood pressure. He is alert, oriented to time and place, but unable to provide the correct date. Abdominal exam reveals a distended, non-tender abdomen with shifting dullness. Neuro exam reveals asterixis. Okay, so great. So most likely diagnosis here. This one's a little bit more challenging, but it's something that we've talked about already today. Great. Mm-hmm. 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 Asterixis is when you kind of have this shaking of your hands. It's something that we see in cirrhosis. It's sort of another sign that neurologically he's not all there. He's got a lot of ammonia and whatnot. So great. So definitely it seems like he has cirrhosis. I agree with you. And we talked about how with cirrhosis, we end up having a buildup of ascites in the abdomen. Okay. Excellent. Yes, great. So this is going to be our spontaneous bacterial peritonitis. And one of the things I love about this question that I really want to point out is that when you have a bacterial peritonitis, you don't have to have a tender abdomen. I know when we think about peritonitis, we think guarding, rigid abdomen, nobody's going to let you touch them. With a bacterial peritonitis, sometimes you're going to have a non-tender abdomen, okay? And that kind of goes to the neurological status of the patient and their ability to really communicate what's bothering them and whatnot. So, sort of a lot of different factors at play, but you're absolutely right. This history of cirrhosis with this some sort of infection, with the shifting dullness and that acute decrease in neurological status definitely points to SBP. Okay, great. So next best step. Okay. You could do ultrasound, absolutely. I love it, yes. I love ultrasound for imaging. I love that, yes. Now, so that would be imaging, but we don't have to do imaging. We can also do some sort of lab work, okay? And so, with this patient, what is one thing that you need to know in order to give the best treatment? Mm-hmm. Mm-hmm. Yes. That was my way of trying to give a clue. But essentially, we have a bacterial infection here, right? Yep, absolutely. We're going to do a CBC, and then so that we can give the best antibiotic. Exactly. Yes. And so the way that we do that is we're actually going to do a paracentesis. We're going to put a needle into the abdomen. We're going to use the ultrasound to do that too, which is why I love that you said ultrasound. We're going to put a needle into the abdomen. We're going to drain out some of the fluid there, and we're going to culture that fluid. Okay. So we have this patient, this would really be in the hospital or the ER. We have this patient where we want to culture, but we also want to start antibiotics. Which would you do first? Would you get the ultrasound machine, do the paracentesis, or would you want to just start antibiotics before doing that, kind of like prophylactically, give a really broad spectrum, and then do the paracentesis and culture? Which do you do first? Yep. Right. Very good. Very good. And you will be asked about this, I guarantee it. I guarantee that. So, okay. Definitely. Yeah. We'll do we'll do a whole antibiotic lecture. Yeah, it's going to be painful for you, but we will do that. That's how you learn. So you're absolutely right. We need to do the paracentesis and culture first. We don't want to increase, antibacterial stewardship, right? We have to be responsible here. We don't want to increase resistance. And the second thing is, if we give an antibiotic and then that antibiotic goes systemically in this person's blood, goes systemically into the peritoneum, and then we take that sample and we try and culture it, nothing's going to grow, right? This bacteria is going to be bathing in antibiotic, and so we cannot do that. So excellent. Yep, we want to do the culture first. The most common bacteria implicated, so it's just going to be one of your typical GI bacteria because that's where it's coming from, is your GI tract. So think E. coli, Klebsiella. Those are going to be, any of the bacteria that you really associate with GI tract are going to be common offenders. Okay. Great. So, acute bacterial infection of the peritoneum without a focal source. Essentially, this is just bacteria that's making its way over the wall of the GI tract and causing an infection. This is pretty common. So 1 out of 5 patients with ascites will get SBP. And this is why when we talked about cirrhosis, why I said it's so important that you start those broad spectrum antibiotics on these patients, because, this particular infection can be deadly with the sepsis and shock. And it's pretty common with 1 in 5 patients developing this. It also has a high recurrence rate. So if you have a patient who's developed SBP in the past, chances are they're going to get it in the future. Most commonly, you're just going to see a single organism, E. coli, Klebsiella, strep pneumo. Typically won't be any anaerobic bacteria. Your symptoms, confusion is really going to be a big part of the picture. Okay, so yes, this is a cirrhotic patient. Cirrhotic patients get confused. However, for a patient with cirrhosis, typically their confusion is gradual. It takes time. Think about a dementia patient. It's kind of like a similar slow decline like that. When you have a patient that's at a certain level of neurological functioning, and then suddenly that level drops, then you think, okay, something just exacerbated what was already going on in this patient. And I want you to think of this bacterial peritonitis. Okay, that's a big part of the picture. Abdominal pain, you can see fever, vomiting, diarrhea. You can see peritonitic signs, so abdominal tenderness and rebound. You may see no tenderness and no rebound. It can really go either way when it comes to SBP. That fact alone won't point you necessarily in either direction. All right. Distended abdomen, you want to look for that fluid wave, which is essentially when you have patients with a very distended abdomen with a lot of ascites. When you push on one side of the abdomen, you can kind of see a wave of that acidic fluid moving. I'm not sure if you've seen this in the hospital before, but it's pretty... You've heard about it before. I personally haven't seen it either, although I have seen pretty distended abdomens. I couldn't quite get it to have the wave, I was pushing and pushing on the abdomen, there was no wave. Yeah, right? Yeah, I just imagine, I don't know if you watch The Simpsons, but there's this one where Homer Simpson kind of slaps on his gut and it kind of just keeps going around and around the wave. Yeah, like a ripple effect. Yeah. But no, I've never seen that, but I guess they can describe it for you. And then again, worsening encephalopathy, a decline in neural status, that's going to be your most common presenting symptom. So our diagnosis, we're going to do a paracentesis to take out some of that fluid. Look for elevated white blood cells, neutrophils, a gram stain in culture. There's also this is kind of like getting into some gastroenterology type stuff, but there's a gradient between the albumin in the serum and the albumin in the acidic fluid. And if you see that gradient is greater than 1.1, that tells you that it's probably due to transidate rather than exudate. Again, kind of advanced stuff. I wouldn't really worry about it for your exam. I don't think that they will be asking you something on that. Okay. Blood culture, urine culture, CBC, CMP. And then, so we'll give those antibiotics. Aldosterone antagonists like spironolactone. We want to diurese our patient and, we don't want to lose too much potassium. And so spironolactone is a good option. And we want to reduce the salt in our diet. Okay. Alrighty, so we're just going to skip this. This is just about the SAG gradient, which I don't want you to worry about. So just our high yield points here. Acute bacterial infection of the peritoneum, typically in patients with ascites. We talked about the bacteria that are most commonly implicated, and confusion should be a big part of our picture, along with all the other signs of ascites. Peritoneal fluid analysis, look for white blood cells, neutrophils. Antibiotics, cefoxitim, antibiotics of choice. Again, it's just such a nice wide spectrum cephalosporin that's not really one of our big gun antibiotics, and that's why you're just going to see this being used again and again. Ceftriaxone is another third generation cephalosporin we can use, or you can use a quinolone plus metronidazole. Okay. Aldosterone antagonists such as spironolactone to kind of diurese our patient and reduce salt in their diet to reduce the amount of ascites. Okay. Alrighty, great. And we will move on to our next case here. All right, so we have a 39-year-old G2P2 woman presenting to her primary care physician with a sensation of undigested food in the back of her throat and chest pain following meals. Okay, so kind of moving away from the colon finally and up to the upper GI tract. What are we thinking about with this undigested food and chest pain? Okay, good. Good. Excellent place to start, yeah. So moving here, she reports difficulty swallowing solids and liquids that started during her last pregnancy, has continued over the last year following delivery. Again, this is absolutely something that can come in a GERD type picture. Okay. On multiple occasions, she has found undigested food on her pillow in the morning. Maybe not something that's typical of GERD. She reports losing 12 pounds over the past 2 months due to the discomfort she feels after eating. She has been taking famotidine and omeprazole for her symptoms, but reports no relief. Her physical exam is normal. Abdomen non-tender, non-distended, soft, normal bowel sounds. Okay, so most likely diagnosis. So the only thing is, I agree with you. This question stem is beautiful for GERD, except for one thing. This woman has taken famotidine. Yes. Exactly. Okay. H. pylori. H. pylori definitely, yeah. So if H. pylori is causing some sort of reflux, you would see that. But again, you should see some relief with antacids, right? You're not going to have complete relief because now you have a bacterial infection on top, but some relief you should see. So here, we're actually going to be looking for some sort of obstruction in the esophagus. Why do I say obstruction? She's having difficulty swallowing solids and liquids. Okay? So rather than just having, pain following that, actually, when she puts these things in her mouth and tries to swallow them, it's difficult for her. She can't actually swallow it. And then following that, she has this pain. And so this is going to be actually due to one of two things. She could have had GERD for a long time and has now developed some sort of adenocarcinoma of the distal esophagus. Exactly. Yeah, very good. Barrett's esophagus. We now have cancer in the esophagus that's causing an obstruction down there. That's one possibility. The second possibility is something called achalasia. Achalasia is when we have some damage to the nerves of our esophagus that does not allow for relaxation of the lower esophagus. Okay? And so those are sort of our two choices here. Next best step, how do you want to go about figuring out what of those two options it is? Yes, we're down to Barrett's esophagus or achalasia. Good. Good. Excellent. Endoscopy, 100%. We can actually look at what's going on. If there's a tumor, we can biopsy it. It's a great test. Okay. Is there any, and that is the correct answer. I just want to say that was really all I'm looking for. But to really push you, what is another test that we can do to look at the esophagus from the outside? An imaging test we can do to look at the esophagus. Yes, excellent. Very good. Barium swallow will show us basically the gross anatomy of the esophagus. We can look and see if it's dilated, okay? And so on this patient, we do the upper endoscopy. We don't see any cancer, but we do see a very tightly clenched lower esophagus. On our barium swallow, we see a very dilated esophagus, full of that barium, and no barium in the stomach. And that is going to be indicative of achalasia. Okay? Again, you do the upper endoscopy. You don't see any change in the tissue in the esophagus, which is what you would see in Barrett's esophagus. We do a biopsy, and we don't see any change in that tissue. But on the barium swallow, we see a dilated esophagus, which gives us our achalasia. Okay, excellent. So treatment strategies for achalasia, and we'll talk about in the next slide, actually. I'm not going to repeat it twice. So achalasia, This is a inability for the lower esophagus to relax with some esophageal dysmotility sprinkled in. Essentially, the nerves that are in the wall of the esophagus are gone. And so some of the nerves are going to be there to tell the esophagus to clench and move food forward. Those are gone. And then the nerves that are there to tell the lower esophagus to relax, to allow food to move from the esophagus into the stomach, those are gone too. And so, secondary to all of these things happening, what we end up seeing is, if you look at this, it's called bird's beak deformity on barium swallow, our lower esophageal sphincter is completely contracted shut. Okay? And so this presents with dysphagia for solids and liquids. This is going to be one of our big clues in terms of finding our diagnosis. Barium swallow study shows a dilated esophagus with a sharp tapering. If we, instead of seeing this sharp tapering, if we saw like a corkscrew pattern of our esophagus, where the esophagus looks a bit like this instead would be our diffuse esophageal spasm, which is a much more rare disorder and something that you would be unlikely to see in clinical practice, but something that is there as well. Our gold standard for diagnosing this is manometry. Manometry, we essentially put a balloon in the esophagus and measure the pressure as the balloon moves down the esophagus. Okay? That's our gold standard for diagnosis. Yeah, we swallow a balloon. Yeah, not fun, right? So, in terms of treatment, our goal here is just to dilate that distal esophagus. We can do it medically, we can do it mechanically, and the way it works is it tends to be a little bit better treatment to do it mechanically. And so, a sphincter myotomy, where we surgically go and we remove part of the muscle in that part of the esophagus, is really the first line and the best treatment for this condition. Surgically remove some of the esophagus. Another treatment strategy would be to put another balloon down the esophagus. When we get to that part of the esophagus that's constricted, inflate the balloon and make a, sort of that, dilate that lower esophageal sphincter. It's 80% successful, which is pretty good, I guess. But there's this problem of a complication rate. So when you have a complication in this particular procedure, that means that you are rupturing your esophagus. Not good. Not good. That is a very serious complication, and so you really won't see this done too often. Other medical treatments available: nitroglycerin, anticholinergics, calcium channel blockers, opioids, varying degrees of not really being that great of a treatment. Okay, those will really be reserved for patients who are saying, I do not want surgery, I hate surgery, I'm not going to do it. Then you can maybe start thinking about giving them some nitroglycerin. Would be probably your first go-to. Okay. Local Botox injections can work as well, although not that particularly well. One important fact is that even after you treat achalasia, there is an increased risk for squamous cell carcinoma. And if you were to have squamous cell carcinoma, it would be in this area of the lower esophagus. Now, the reason that that's important and the reason that I left that in there is because typically when you think about cancer of the lower esophagus, it's an adenocarcinoma, like the one you told me, Barrett's esophagus. That is an adenocarcinoma. Squamous cell carcinoma, you really only see in the upper esophagus. Okay, in your smokers, your alcohol drinkers, you see squamous cell carcinoma in the upper esophagus. The only way to get squamous cell carcinoma in the lower esophagus is in a patient with a history of achalasia. Okay? Questions on achalasia? No? Okay, great. So this is just showing you a bit of manometry and what that looks like. And so going from our upper to lower esophagus in our normal patient, what it looks like is we have this progression where we have, as we move down the esophagus, we have this wave of pressure that moves down the esophagus, and ultimately we get a relaxation of our lower esophagus as the pressure drops from about 40 to 0. And this drop is representing the movement of that food bolus from the esophagus into the stomach. That's what we need to see. We need to make sure that the lower esophagus is relaxing. In achalasia, what we see is it starts out fine. We have this progressive movement of muscle contractions down the esophagus. As we get towards the lower esophagus, those contractions get weaker. And at the lower esophageal sphincter, it doesn't relax. So that means that food is not able to move from the from the esophagus into the stomach. That's what this means. Okay? In scleroderma, this is a rare condition where we see very little contractions and a very loose lower esophagus. And diffuse esophageal spasm, we have very strong contractions that are not progressing in a very organized way. Okay? So the name of this testing is called manometry. Okay? And this is going to be our gold standard for achalasia. Got it. Okay, great. And our high yield points, we kind of just talked about it. Great. Okay, great. So case number 10. 25-year-old woman presents to her primary care physician for recurrent abdominal pain. Okay, again, this could be really anything. Yeah, same. Maybe we can throw in some ectopic pregnancy, PID, things of that nature we want to kind of loop in there because they can present with abdominal pain as well. She describes having daily episodes of crampy lower abdominal pain and diarrhea for the past 6 months. Her diarrhea has occasionally been bloody, and she has experienced an unintentional weight loss of 10 pounds over the past 3 months. She adds that she has had a subjective fever over several nights last week. Physical exam, a slight elevation in temperature, pulse 96, and blood pressure is a little bit low. Appears thin, but is in no acute distress. Abdominal exam reveals diffuse tenderness. Rectal exam is significant for frank blood. Okay, so most likely diagnosis. What are you thinking of in this case? Okay. Mm-hmm. Okay. Okay, good. So definitely those are big concerns we need to think about with a patient such as this. What do you think about this weight loss? Not good, right? So I really want you to loop all of these things in together. You know, this is Christmas time. We're making a present and we're going to put a nice bow on it. What are you giving me for Christmas? Mm-hmm. Mm-hmm. Right. I agree. 100% I agree. Okay. Mm-hmm. Good. Yes. So we definitely have some sort of GI bleed, and it's probably pretty low, right? We're thinking either a GI bleed in the descending colon, sigmoid colon, or rectum. Because if we have a GI bleed that's maybe, in the duodenum, what would we see? Instead of frank blood, we would see what? Exactly. Good. We would see something called melena, which is just dark digested blood. Okay, but like you said, we have some sort of GI bleed that's pretty low. Now, I want you to think about these daily episodes of crampy abdominal pain and diarrhea for 6 months. This diarrhea has gone from being regular diarrhea to now being some bloody discharge. You know, excellent. Very good. Yes. So it's either ulcerative colitis or Crohn's. It's one of our inflammatory bowel diseases, right? And that should really be where you are right now between those two answers. And if this was your question on the AANP exam, you would have one of those two as an answer choice, but not both of them, if that makes sense. You wouldn't be forced to choose with a presentation like this, because all you can really say is inflammatory bowel disease until you do a colonoscopy. Okay? Excellent. So what is required for diagnosis? I think I kind of gave it away, but what would you need to do for diagnosing this? Okay, good. So CT would show us, in general, we could look at the colon. We could see some of the strictures if it's Crohn's disease. We could see, an abnormal looking lower colon if it's ulcerative colitis. But what you have to have for diagnosis is a biopsy. A biopsy will reveal under a microscope exactly what the pathology is that's going on. Okay, so required for diagnosis is going to be a colonoscopy with a biopsy. Now, you've worked in the hospital, I've worked in the hospital. We both know that the first thing we would probably do is a CT and just get a general picture of what's going on. But you know how these exams are. It's not real life, right? Yeah. So, treatment strategies. We mentioned it briefly before, but the go-to drugs for inflammatory bowel disease are called mesalamine and sulfasalazine. They are both anti-inflammatory drugs that help with all of the symptoms of inflammatory bowel disease. If your patient is having an acute flare-up, you can also do a corticosteroid. Corticosteroids reduce the immune system and will reduce the amount of inflammation. Okay? Wonderful. Yeah, no problem. Go ahead. All right, no problem. Nope, it's okay. So, we said that at this point, where I'd like you to be is this is some kind of inflammatory bowel disease. Getting into the nitty gritty about what's more likely here. You have some things that point you towards Crohn's, and you have some things that point you towards ulcerative colitis. For example, frank blood at the rectum tends to be more ulcerative colitis. Ulcerative colitis starts at the rectum and then starts moving proximally. Okay, so the rectum is always involved in ulcerative colitis versus Crohn's, which kind of randomly involves different parts of the GI tract. Okay, so that kind of goes towards Crohn's. But then at the same time, this patient has been having diarrhea that is only occasionally bloody. Patients with Crohn's disease tend to have non-bloody diarrhea initially. So again, just kind of reinforcing that you should be at inflammatory bowel, but that's really all you can get starting off on this question. So let's talk about the two conditions and the disease in general. Ulcerative colitis, this is a mucosal disease. This is involving the mucosa. You can see, here's our ulcerative colitis. It's going to involve the rectum and extend proximally. If we look at our image here, inflammatory bowel disease, what you see is that the rectum is involved, and as you move up the descending colon towards the transverse colon, now it's kind of died off, but it's continuous. There's no spots. Okay, let's compare that to our Crohn's disease. On our Crohn's disease, you can see here the sigmoid is involved, and then we have a gap, and then we have part of our transverse, and then we have our cecum, and then we have it's just sort of here, there, everywhere. That is going to be more typical of Crohn's disease, where ulcerative colitis is continuous involvement of the GI tract. Okay. In terms of your patient presentation, look for anyone age 20 to 25. More common in whites, especially the Ashkenazi Jewish population. Crohn's disease, rather than being mucosal, this is transmural, involving the entire wall of the GI tract. And you can see here, these fissures that go all the way through the wall is really typical of Crohn's disease. This has a bimodal age distribution where you see very young patients and very old patients being presenting with this disorder. Women are affected more commonly than men, more common in whites and Ashkenazi Jews as well. Okay, just sort of a random fact. Smoking increases your risk of Crohn's disease, where, believe it or not, smoking actually decreases the risk of ulcerative colitis. Okay, so should you recommend all your patients start smoking? Probably not. Probably not. The risk, the risks. Yeah. Exactly. Yeah, you should always do smoking cessation. You never but it's just sort of a random fact there. Symptoms here. So for Crohn's disease, we're going to look for abdominal pain, a low-grade fever, weight loss, watery diarrhea. If there's a rectal involvement, it would be in the form of fissures or fistulas rather than frank bleeding. Okay. For ulcerative colitis, look for bloody diarrhea, tenesmus or pain in trying to defecate, and crampy abdominal pain. All right. For diagnosis, we can do the abdominal x-ray. There's not a lot we can see there. This is kind of ruling things out. Stool examination for bacteria, C. diff toxin, oviparasites. The reason for all of these things is just to rule all these things out. Okay. Like you said, I think on a previous question, when you have a patient who is having diarrhea over, an extended period of time with a fever or even a low fever, you really want to start thinking about C. diff. And so rule that out every time. But if you want to diagnose this, you need that colonoscopy with a biopsy. All right. A contrast barium enema can reveal certain things in Crohn's disease, but it's not necessary to have that. For our treatment of these diseases, they're both treated with sulfasalazine and mesalamine. Okay, and that makes it pretty easy in terms of no matter what the disease is in the question stem, it's going to be one of these two treatments. If you have a disease that is not responding to those anti-inflammatory, give them a corticosteroid, give them an immunosuppressant, and that should help to induce remission. Okay. For ulcerative colitis, because it only involves the colon, if you take out the colon, you will actually cure your patient. Okay, so that's sort of a little caveat there. And last, our prognosis. So patients with long-standing ulcerative colitis have an increased risk of colorectal carcinoma. That is not also true of Crohn's disease. Only ulcerative colitis do you need to screen for colorectal carcinoma. Okay. What screening do we do? We're going to do an FOBT and colonoscopy 8 years after diagnosis, and then every 5 years. Okay. So 8 years after diagnosis, and then every 5 years, we will do that colonoscopy. Mm-hmm. That's true. Yeah. That's a good point. So that is for the general population. If you had someone with IBD, this screening schedule would overrule that one. And so they would be getting them more frequently. If that makes sense. Yeah. Okay. Excellent. So what do we have here? Okay. Case 11. So we're going to stop there.